Good afternoon, and thank you very much for the opportunity to address this inaugural Sphere conference, and I hope to see many more for the future. When I was asked to speak in the squeaky wheel section, I didn't know whether I was the squeaky wheel and they were just trying to silence me, or they were hoping I might have some insights into squeaky wheels. I have many squeaky wheels, and I think that's what's one of the most complex aspects of health policy. We have squeaky wheels from Treasury, we have squeaky wheels from the Commonwealth, we have squeaky wheels from clinicians who constantly ask for more resources. We have squeaky wheels from researchers that would like more government funding. And last but not least at all, consumer expectations are big squeaky wheels. So how do we get the oil to do it well and grease the wheels? And it is a challenge. And it took Mr. Trump a little bit longer than most of us to realise that who would have thought healthcare could be so complicated? And it is. But once it's in your blood and you're passionate about it, you can't go back. So, understanding what the audience was here today, I just thought I'd give you a snapshot of what New South Wales Health is, because as I came earlier at the tail end of the morning sessions, I didn't recognise a lot of health faces, and I know we've got some international visitors. So that's some of the metrics of the New South Wales health system: 115,000 staff, 270 babies are born every day. It is the largest health system within Australia. And shifting policy direction is like shifting the Titanic. The most important thing to understand is that the New South Wales health system and the Australian health system generally are well regarded, but we're not immune from the challenges of health service delivery that every other country experiences. And sustainability of the health system is something we as custodians are responsible for, and good health policy will be critical to ensuring the sustainability of that health system. Within New South Wales, or within Australia, we've just hit the 10% mark of GDP, so all eyes are upon us. But we do perform very well, both in the Australian context and the New South Wales system. If we look at the document from the Commonwealth Fund, and we even look at our Bureau of Health Information report, New South Wales compares well and the Australian health system performs well. And as a nice segue from Lisa's presentation before, the area that we are not so good in is equity. And that's something that we really need to look at in how we deliver our services. The sustainability of the health system funding is a challenge both at a national and a state level. And the New South Wales Treasury did an intergenerational report for government. So that's my other squeaky wheel, Treasury, and spell out a picture of doom and gloom of the future forecasts for the cost of health funding within the state. And currently, health is the biggest expenditure of government. Roughly about 27% of the state's expenditure goes on healthcare delivery, and by 55-56, as you can see, it jumps to about 35% or slightly more. So the naysayers are very concerned that the future of healthcare is going to be unaffordable within the state. I actually say they could maybe give up some education or some police force or the environmental factors, but that doesn't win votes either. So one of the complexities that we have is that health funding is complex. Because of the Commonwealth state relationships, because of the Commonwealth funding primary care, the pharmaceutical benefits scheme, and states running the hospitals. But as indicated there in the diagram, our budget for 17-18 was $21.6 billion. So that's what it takes us to run the New South Wales health system, and I'm horrified when it's translated to 59 million per day. The proportion of the various contributors to the health funding are listed there, and state at 51%, Commonwealth at 28%, and I'm glad Martin's not in his current role there still, so we didn't have any tensions between the funding sources. We generate revenue and non-cash sources. So it is a big, complex budget, and the demands are overwhelming. And that's our challenge going forward. So, when I was appointed Secretary for Health, it was the Premier at the time that said, where are we taking the health system in New South Wales? What's our direction? What's our policy? How are you going to manage the future of the healthcare delivery? One thing I've realised in this role, issues management could occupy 24 hours a day, 7 days a week of running the health system. But if we are to have an impact, if we are to make a difference and commit to sustainability of the health service and continue to deliver the best outcomes we can for the population, we have to have a collective vision of where we're going. And in my thinking and from my readings, value-based healthcare or better value healthcare creates us a very good policy framework to pin the future direction on it. And inherent in that, and the way we've adapted it within New South Wales Health, that came through in some of the commentary this morning, the patient experience and the patient outcomes are vitally important and the centrepiece of what we need to get a better handle on within healthcare. Consumers will and should have a say in the way we deliver our services, and we need to adapt our services to make sure it meets their expectations. They need to be engaged, as Lisa said. But also, we need to look at those patient-reported outcomes and the medical quality. The variation in clinical practice within New South Wales, across the country and even internationally is incredibly varied, and we need to look at some of those variations in practice, to look at whether we're delivering low-value care or futile care and start to challenge some of those conversations. And the net result of those factors will actually then ensure we have the largest amount of value per patient spend. We can't keep going back to Treasury year in, year out and say we need more money because the population's growing and we've got lots of new and exciting technologies and innovations. And I always temper conversations about the shiny, bright, new, innovative things of the future with the reality check that who will pay for some of those and will they make it better for the patient? Because it's terribly seductive looking futuristically, and I enjoy it too. But one of the panel members this morning, and I can't remember who it was, but said, you know, it's not all about innovation. It's about applying what we know works and applying it systematically across the health system is what we need to look at. So how we're moving better value care forward, and we don't have all the pieces in place. It's an iterative design process that we're looking at, which in some quarters I think sounds a little bit like making it up as you go along, but often in policy constructs you don't have the luxury of starting from a greenfield site or having everything in place before moving forward. So I'll just touch on a few of the aspects here in New South Wales, what we're doing, to give you a flavour of how we're moving the better value care agenda forward. I think traditionally we've been somewhat missing in action in the patient outcomes and patient experience area. We often wax lyrical about patient care and we're designing the system around the patient, but I think in some instances it's rather cursory or superficial, the attention that we give the patient-reported measures and outcomes. So we're looking at mechanisms of incorporating the patient measures and outcomes into our electronic records. And I think that's one thing that's at the forefront of our mind. We can't create extra systems and burdens to deliver this information if we can build it in. And we've had discussions about whether we go the clinical registry route, like a number of other countries have done. But at this stage, we're working on a solution to see how we might be able to incorporate some of those measures into our routine recording and reporting. The next most important area we needed to look at was the delivery organisations which will help us on this agenda, and also the areas that we wanted to focus on first. One of the most important things I felt was that we had collective focus on the system for a number of priorities to get a system-wide effect. The complexity and breadth of what we have in the health system really makes it difficult to keep people's focus and then get a measurable system effect. So we've picked 8 clinical initiatives and what we're having the conversation is these will be our tranche 1 focus, and we're not precluding any other activities that may be consistent with the better value care approach. But I want to be able and have the capacity as a state to look at measurement of shifting the dial, and we need a statewide effect to be able to achieve that. This is where I believe our partnerships and collaborations are absolutely critical. The hospitals need to work with the primary health networks, and I'm delighted also that the academic health centre sphere, we've had a conversation as to how we can really facilitate the delivery and understanding of the better value care agenda through the expertise brought, through research, through data and analytics, so it will be critically important for us to partner. Dare I say, in typical Treasury style, Treasury said, well, you've developed tranche 1, let's move on and say, what do you want to do for tranche 2? I think there's a bit of a reality gap in understanding that implementation methodology does take a considerable amount of time. We will be benchmarking and researching for the program because the conditions we chose do have a strong evidence base. We developed the models of care in consultation with clinicians through the Agency of Clinical Innovation, and we want to make sure that we have sophisticated measurement and research around what we're doing to really emphasise and, I guess, test the proof of concept around better value care. Most important thing I'd say also about this journey on better value care, it has a lot more acceptable resonance with the healthcare professions and really hits home that the patient outcome is at the heart of it. Traditionally, when Treasury attempts to talk about efficiency and productivity, it falls on deaf ears. But this, I believe, is something that has a real value add, obviously, to the patients, but has a concept that sits well with clinical professions. To support it, our e-health systems in New South Wales, we've been on a very long journey of implementation of an electronic medical record across the state. It has been a rocky road, and the challenge that we've had in the initial years in the first horizon is about consistency of the foundations. We've taken a different approach to other states in New South Wales in having a standardised electronic medical record, and that I think will be absolutely critical to interfacing with the My Health record, the primary health network at a state level, and enabling that interoperability between primary care and the hospital setting. Integration of that electronic health record is critical, and we've got a longer term view that by the time we've put all the foundational elements, we will be approaching personalisation of that healthcare and the customisation of the healthcare that we deliver. In looking at how we can incentivise this, because for those who implement policy, it unfortunately doesn't happen by edict. One needs some policy levers to be able to move. Capturing people's hearts and minds that it is the right thing to do is very, very important. But we need to look at how we can incentivise and support the delivery of that policy. And we're having a look at some of our funding models. We've had a journey with activity-based funding over a number of years, but my contention consistently has been we're paying for activity, we're paying for volume, but we don't necessarily know whether we're paying for value. So we're looking at introducing some modifications to our hospital funding system that might incentivise some good care. The evidence seems rather dubious about paying for performance, but I think it's a space that we need to watch for the future to see how we might really incentivise the quality of care that we provide. So the policy landscape is complex. The value that the community sees in our health services is very, very high, and they're very well-regarded health services that the community holds and cherishes closely. Better is possible for us, and I agree that it does not take genius. It takes diligence, and it takes deliberate action on our behalf. The clarity of what we're trying to do is absolutely critical, and we just have to give it a go. I'm willing to try. So thank you.